Hello, and welcome to this evening's VCU Health virtual seminar on pancreatic cancer. My name is Blake Belden, and I'm a member of the marketing and communications team at VCU Massey Cancer Center. Today we are joined by Dr. Jose Trevino, who is the surgeon-in-chief at Massey Cancer Center, and he will be discussing basic and clinical research efforts that address pancreatic cancer disparities and pave the way for more personalized medicines and better quality of life for patients with the disease. Before we begin the presentation, I would just like to note that we will hold all questions until the end. Please feel free to drop any questions you may have in the comment section on Facebook throughout the event, and we will address those during the Q&A portion. Dr. Trevino is also the chair of the Division of Surgical Oncology at the VCU School of Medicine and holds the Walter Lawrence Jr. Distinguished Professorship in Oncology at Massey. He has expertise in liver, bile duct, and pancreas surgery, and he also conducts research with specific interests in pancreatic cancer. He currently holds multiple grants from the National Institutes of Health and the Florida Department of Health that support his work examining pancreatic cancer biology and the tumor microenvironment, cancer cachexia, novel therapeutics, and how all these relate to pancreatic cancer health equity. He recently conducted a groundbreaking study on ethnic subgroups and pancreatic cancer outcomes, published in the journal Cancer Medicine, which was one of the first to examine the connection between the disease and ancestral racial diversity among Black and Latinx populations. Thank you, Dr. Trevino, for joining us today. I will now turn the show over to you.
Great. Thank you very much for having me, and I'd like to say hello virtually to everybody who's here to hear my talk. And so let's get started. And so the title of my talk today is Pancreatic Cancer: Using Precision Medicine to Address Health Disparities. So here are my objectives. Something that I think will help us along the way of this talk. First of all, why do we want to study pancreatic cancer? What is pancreatic cancer? I think that's another question that I think is very important. We'll also be looking at the signs and symptoms of pancreatic cancer, as well as systemic implications. In other words, what does it do to you? Outside of people knowing that it's just a cancer that eventually kills, there are a lot of things that this particular cancer does. And ultimately, we'll also look at how pancreatic cancer is a health disparity, something that's up and coming, and I think is incredibly important for us to understand. The more we understand about our diseases, the better we're going to be able to treat them, and including if it has a certain predilection toward Latin patients or Blacks. So one of the reasons that I chose to do pancreatic cancer is because it's very clear that it is going to be a serious killer that we're going to have to contend with in the near future. Currently, it is the third leading cause of cancer-related death in this country. And by the year 2030, it will be the number two. In other words, it will be the second leading cause of cancer-related deaths in this country, just below lung cancer. And therefore, as we see it rise, or as we see it kill more patients every year, we have to start taking note that we have to do things to help better understand this disease as well as treat it. So here's kind of a brief picture of what I do. I'm a surgeon. I operate on the pancreas. I've been operating on the pancreas as a faculty member for the past 10 years. But at the same time, I do a lot of research in it. And I try to understand the biologic basis of this disease. And the importance will become very evident as we start to talk more and more about what pancreatic cancer is and why it's so difficult to treat. So let's start with some basics. Let's start with some basic things. So what is the pancreas? What's the pancreas function? Well, the pancreas has two main functions, and then we're going to throw some kind of higher words like endocrine or exocrine. And for the most part, endocrine just means that it produces sugar. It produces, insulin that controls our sugars and controls other hormones as well. But for the most part, one of the major things the pancreas does is produce insulin, which controls the level of sugar in our body. It's very important for us to do that. And this is kind of where people start to understand diabetes a little better. The other part is exocrine. And what that does is this produces juices that will allow us to better digest our foods, better digest our fats, our carbohydrates, etc. So this is the two main functions of the pancreas. And as you can see, there's a picture of a human body, and the pancreas lies right in the middle of the body. And so when people say they have abdominal pain or stomach pain, sometimes that's referring to the pancreas. What are the risk factors for pancreatic cancer? In other words, how do you get this? Or how do you increase your risk of getting this? Well, there are some things that we do know and some things we don't know. But one of the things we do know is that increased body mass index, in other words, being overweight, has a higher chance of developing pancreatic cancer. Drinking too much alcohol will irritate your pancreas over and over and over again. And some of you may know that if you drink alcohol on a very, very high level, some people will develop a condition called pancreatitis. And that's just a fancy word for saying that your pancreas becomes inflamed because the pancreas becomes overwhelmed with the alcohol use that you're doing. The other thing that can cause is a risk factor for pancreatic cancer is smoking. And cigarette smoking, as we know, tobacco is bad for all sorts of health, so all sorts of human health problems. But we also remember that smoking can also have something in it like nicotine that can cause these problems as well. So smoking, vaping, chewing tobacco are all risk factors for the development of pancreatic cancer and the progression of it. There's some evidence to believe that there are inherited gene mutations, and we do know that genetic syndromes, in other words, if mom had it and grandpa had it and great grandpa had it, there might be a genetic component in your family that can lead to the development of pancreatic cancer in yourself and others in your family for generations to come. Things we need to understand. And then obviously the occupational exposure to chemicals. Chemicals can be toxins. They can be carcinogens, in other words, develop cancer if you're exposed to it for too long. So what are the signs and symptoms? This is something that comes around a lot, and people really have to think about this because this disease is so incredibly deadly that by the time that we catch it, in other words, by the time that it's diagnosed, most of the time patients are already at a very late stage, and we rarely can do much about it. And so what we're learning nowadays is at least these days, is that we have to start thinking of ways to pick this up earlier. Are there signs that we might be able to use toward helping us? And one of the things that people have done is that if you suddenly develop diabetes when you've been an otherwise healthy individual in your 50s, 60s, or 70s, that could be a sign that your pancreas is starting to become dysfunctional. Remember what I said earlier in the talk, that the endocrine part of the function of the pancreas is for sugar control. So if the pancreas stops working and you start to develop diabetes for no reason, you're otherwise healthy and you become diabetic, there is something happening to your pancreas that needs to be investigated. So there is an increased chance of those who suddenly develop diabetes, not based on biological or metabolic syndromes, they just develop diabetes, that they should be evaluated for the development of this disease because it could be one of the earlier signs that might save your life. Another sign or symptom of pancreatic cancer, you suddenly start to lose weight, and you're not trying to lose weight. And these signs are typically because the cancer is nutritionally heavy. It wants nutrition, and so it starts to slowly waste away your body stores, your energy stores, and that causes you to lose weight. And again, unintended weight loss. You can start to have what's called acolic stools, malabsorption, and dark urine, all of which we'll talk about in the next slide. But your stool turns pale. You start having a lot of grease from your stool, and then your urine turns really, really dark. And also pain. Remember that picture of the anatomical figure showing where the pancreas was? They get very central, or what people call stomach pain. Things, again, we need to note. All these can be signs and symptoms of pancreatic cancer. But one of the things that most people present with pancreatic cancer is the idea of this thing called jaundice. And it's painless. In other words, people just all of a sudden say, you know what, doc, I started to turn yellow. And not only am I turning yellow, my eyes are turning yellow, my stool is turning white, and my urine is turning dark. And what happens in that situation? Well, up in the upper right-hand side of this image, you can see a picture of the liver, the gallbladder, and the pancreas. And so the pancreas is the yellow colored figure next to this green colored tube and this green colored gallbladder. And what you're going to note is this, is that when the pancreas develops a cancer, it obstructs that green tube. And it's very much like your toilet backing up. It just causes that green content to back up into the liver, and then the liver will back up into your bloodstream. And guess what happens? Well, that green stuff turns in the blood is yellow, and it deposits in your tissues. and you turn yellow, or i.e. jaundice, and that yellow stuff needs to go somewhere. So it needs to come out of your urine because your kidneys excrete it. And guess what? That yellow stuff subsequently can no longer turn your stool brown, so your stool turns white. And again, these are signs and symptoms of a potential pancreatic mass that should be addressed with pretty soon. And so let's talk a little bit about research, because that's what I do. And so what did I do to really develop my interest in pancreatic cancer and really develop my laboratory to look at this on a biological level? Well, first of all, like very many things that we do well, you have to have an interest in it. You have to believe that this is a great thing to do. You have to have a background in it. I've had a background since 2003. I've been studying this disease for quite some time. Develop some questions. Get your laboratory, get some cell lines, and start looking at how is it that you can affect this disease. And we've done a lot of this. We've done a lot of animal models. We've done a lot of biology, looking at tumors in culture, in petri dishes, and we try to affect its ability, the ability of the tumor to grow on all levels, grow in vivo or in a living system, or in vitro in a petri dish. It's the only way we do real preclinical work. In other words, work that we do in a laboratory to study this disease process. And as we do this, we publish this, we put data out there to try to affect everything we can to try to have people pay attention to the ways that we could really help patients with pancreatic cancer. And these are just a few. But unfortunately, as I've been kind of preluding to earlier, is that things are not that easy. That patients with pancreatic cancer, even in the best of hands, don't have an overall good survival rate. So unfortunately, out of all the patients with pancreatic cancer, only 20% of them will get to surgery. In other words, only 20% of them will be allowed an opportunity for cure. And out of those 20%, at the end of 5 years, it depends on where you go, 20 to 30% of those patients will be alive. But if you take all comers with pancreatic cancer, the survival rate, 5-year survival rate, is only around 9%. So that tells you that things are really bad. And we have to understand why, right? If we don't understand the disease, we won't be able to understand how to solve it, how to cure it, how to control it. And so we take a step back. And so one of the things that I've always thought about was, what is it that we're studying? How do we study this outside of studying this in patients, which in some degrees it can be very harsh if we just decided to quote unquote experiment on human beings. So as I said earlier, we experiment with cell lines. We put these things in petri dishes, and we put these things in animals, and we see if we can figure out a way to control this disease. But the problem is that when we look at this, we start to see what are the cell lines that we were using. And these are the cell lines that I'm going to go through right here are something that some of you might know what they are because you're going to recognize their name, or might not. But for the most part, these are cell lines that were established many, many years ago, and mostly established in white patients. Now, why is that important? Right? We should all be alike. We should all be treated the same. But the difference is that as this talk proceeds, you're going to know and you're going to hear that we're not all alike. And while we should all be treated with dignity as human beings and all be treated the same on all levels, biologically, we're different. And I will convince everybody at the end of this talk that not only am I different than another Latin person from Miami or Latinx person from Miami, I'm different because I have a different ancestry than they do. But we're all Latinos or Latinas. But looking at these cell lines as we go through them, we realize that these are all fairly old, from the 1970s and 80s, and they're from white patients. And so it's hard to believe that a lot of the work that we're doing is based on these cell lines, and we're supposed to have some meaningful data from it. And don't get me wrong, I think sometimes this is all we got. But this is where we have to ask the question as to why we're not making the impact we need to make. And so we take a step back, right? Things aren't working. If you're a scientist and a researcher or someone who studies the literature, you'll understand that there's a site called PubMed, and you can look up pancreatic cancer on PubMed, and you will see over 65,000 publications on pancreatic cancer and how we cured it, but in animals and in petri dishes. But at the end of the day, we haven't touched it. And so why? How is it that we can publish so well on so many levels and yet be able to hardly impact it? And so the question was, what is pancreatic cancer? And so there's a question mark next to that image. And this is what we used to think it was, right? A bunch of cells, cancer, right? All kind of in one big ball. But in all reality, the pancreas cancer looks like this. And this is what it looks like from a patient from an operating room. It's hard. It looks exactly as ugly as you can imagine. It feels that way, and it's deadly. And it's just like an impenetrable fortress. And when we look at it closer, what we see is this is what pancreatic cancer looks like. And if you compare those two images, they are very different. And so we need to understand that there is a complex system that we need to do better understanding to be able to do better in treating it. And so how do we solve the problem? Well, first, appreciate the complexity. We are all incredibly complex. We got to understand the complexity of an incredibly horrible disease. And so we need to understand that there's cancer, that there's immune cells, that there's supporting cells called stromal cells. All this interacts and plays together. And this is what makes this very difficult to treat, because sometimes it's incredibly hard to replicate this in a laboratory setting. So what we decided to do here at VCU and at Massey Cancer Center is to start looking at these patients and looking at their tumors and almost what's called personalize them. In other words, I want to know your tumor. I want to know what your tumor does. What is your tumor going to do? And so instead of just looking at these cell lines from 1970s from white males, and I just said, we need to understand this from every patient that comes through our door. And so we've developed this system where we start to grow these tumors of these individual patients in mice, in animal systems, in vivo systems, in live systems, as well as in culture. And here's just a picture, a brief picture, kind of depicting what we're doing here. And so we're able to look at your tumor on multiple levels to determine what's the best therapy for you. And so as we do this, we start looking at the comparison of these tumors that are being produced in a live system or in culture. And what we note is that we can get very close similarities to what the human tumor looks like. And this just appreciates that bottom row will appreciate how different these cells can be. And so therefore, again, supporting that we are very different, even though we might have the cancer of the same organ system, individually, we are different. And so the other thing we do is what's called 3D systems, in which we're able to do what's called organoids. We get to put these, and then they grow in like sphere and 3D systems. And I think it's kind of the step back from an in vivo system, but in kind of in a culture dish. What allows the three-dimensional growth, which I think is impressive, and something that is used widely now in academic centers for research. So here's just a couple of other things that we needed to pay attention to outside of the personalized aspects of this. We needed to see tumor signaling. So not only were we able to look at these individual patient samples, we're able to look at how the samples themselves were signaling through. And here, this is just a quick kind of outline of one of my prior MD, PhD students who has done a great job and is currently taking a faculty position at Stanford. And he was looking at how the signaling is so affected by these tumors. It's so affected by everything we do. And if you look over to the bottom left, you see all these kind of lines and blots is what I call them. And that's just showing real quickly, and I won't go too deep into it, and there's no real need to get complex. All it's showing is if you add nicotine to these cells from these patients, it shoots a bunch of badness in your body. It shoots these signaling enzymes, these signals that promote tumor growth and metastasis, and will promote your death. And so again, just kind of goes to show, even though smoking is a risk factor, it will kill you if you continue to do it when you have a cancer diagnosis or without. And so here's just a quick show of how nicotine will affect it. And again, we won't get too complex with this, but for the most part, let me just say this. Nicotine and or smoking will cause an upregulation of a whole bunch of badness in that tumor that is going to cause that tumor to grow much faster. So we should understand that is something we should not do, regardless of whether it's a cigarette, whether it's chewing tobacco or vaping. All of it is dangerous. So let's also look at this, and this I think is an incredibly important question. Are we treating the patient or the tumor? Now, I say this because there's a lot of people that think about chemotherapy, targeted therapies. We're always thinking about treating the tumor. But we sometimes forget that there is a very important aspect of that tumor, and that's the patient that it's in. And so we have to always look at the patient on multiple levels, from an emotional level, from a psychiatric level, from a physical level. It's incredibly important to understand the critical need, to understand the clinical need. Is there a problem that we need to address outside the tumor itself? And so I put this up because this is important. We're based off of systems. These are human organ systems, whether it be skeletal, digestive, respiratory, nervous, or circulatory. And what I'm hoping toward the middle of this talk, or toward maybe the end of this talk, you'll understand that pancreatic cancer affects every single one of these systems, very much like a lot of other cancers do. And if you look at the upper right-hand side, I have that smoking kind of with cigarettes and wolf are killers that come in packs. That just tells you that smoking affects everything. And so while this is not a smoking talk, it just kind of promotes the fact that it's a risk factor and also a promoter of tumor growth. So just don't do it. And so we're going to talk about this thing called cachexia. And cachexia is just a fancy term for muscle wasting. And what we're going to show is that pancreatic cancer has a significant effect on that. So here's a CT scan. And this is just a cross-sectional image. In other words, someone took some radiographs and decided to cut you right down the middle like this, to be able to look in the inside of you without actually looking in the inside of you. And what we're noticing is that patients with pancreatic cancer lose their muscle. And most of you got, if you've been unfortunate to have patients in your family or people that you've known that have had cancer, you can see that they lose a lot of weight. And what I was saying earlier was that the cancer has a high nutritional need, and it will continuously eat at every store you got until it either kills you or you kill it. And so it's really, really important that there's a good diet, that there's high protein diet, you're eating things that are going to keep you moving, because without muscle mass, as it will be demonstrated here, you will die. And you see up on the right-hand side, it says alive 4 years postoperatively and survived 2 months postoperatively. These are patients that were surgically resected. But what you're going to note is that the muscle mass that is maintained in the patient that's alive 4 years by the big arrow is much different. If you look at the two arrows, there's much different in sizes, and that's your psoas. That's your psoas muscle, the muscle that lines right along your spine. But there's a difference. And so this was really important for us to see. And one of the things we realize is, and this is just getting a little bit more in depth, but for the most part, if you maintain it and we develop this kind of this average, which is called the psoas indices, to look at muscle loss, if you can maintain that, you live longer. It's a good sign. If you didn't, you didn't. And here we just demonstrated that. I mean, this pretty much just says, these two graphs just say good nutrition, which is monitored by albumin, which is in your blood, or a psoas indices, which we just showed, that radiograph, that if you can maintain your muscle mass, you live much, much longer. Makes kind of sense though, guys, doesn't it? I mean, if you think about it, if you don't maintain your muscle mass, you can't get up. You can't get up, you can't move. You can't move, you're not going to get surgery. And if you can't move, you're not going to get chemotherapy. And think about, without any therapy at all, how quickly you will die from this disease. And so it's important to maintain muscle mass, to maintain strength, to maintain every bit of who you are to be able to fight this cancer. And along the way, as you're getting the therapies, it's also incredibly important to keep this. And this is just some data showing that if you can continue your muscle mass throughout your therapy, in other words, keep moving, keep walking, keep being positive, keep exercising, keep having great nutrition, you're going to do great. You're going to do well. And you will be offered the opportunities that some people just are not. And while I'm not going to get too much into depth here, I want you to concentrate on two things, A and H. And this is just a quick biology, just kind of review. And you do not need to be a pathologist to notice a difference here. A is normal muscle. And this is in a normal patient that had an operation for a benign disease. And if you look at H, that's a patient with advanced pancreatic cancer. And if you look at the difference, you can see a huge difference in the architecture of these muscles. And this just tells you right away, this is systemic. Now, this is muscle. This is nowhere near the tumor. In other words, that tumor is spitting out all this stuff throughout your body, and it's affecting your muscles' ability to maintain normal architecture, normal growth, normal function. And without muscle, what do? Can't walk, can't eat, can't do anything. So think about the ways that this cancer can kill you, and this is one of them. And so one of the things that causes your muscle loss, again, along with the cancer, is nicotine, right? Tobacco, vaping, chewing tobacco. And here's just one of my residents, Pat Underwood, who did a really incredible study looking at what was being produced by the tumor that could cause the muscle to be lost. And we won't go into too much depth here because this can get fairly complicated at times. But for the most part, nicotine would drive the cells to produce these things in your body that would then be throughout your entire body and cause your muscles to fall apart, just like you saw in the previous slide. So don't smoke, don't vape, don't use chewing tobacco, because that only is a risk factor for all types of cancers. Once you get it, it's going to promote every bit of what it's going to take to kill you quicker. And so therefore, nicotine is not, or any form of nicotine is not a good thing. And here just shows you just a bunch of science demonstrating that nicotine will promote not only blood muscle loss in animal models, but also promote this production of all these signaling enzymes that could be really bad for you. So again, it's something we do not want to do. So what about health disparities? Kind of the overall compass of this. Like, this is what we were talking about. We talked a little bit about why it's important that we have diversity in our tumor models with cell lines that aren't just from one particular race, one particular gender, because we are not one particular race or one particular gender. As we maneuver through, we start looking at differences in muscle and things like that, which I think are incredibly important for the disease, understanding it better. So now, what about health disparities? Is there really a problem? And for us, there is. So what about behavioral risk? We know that Blacks have greater morbidity and mortality from tobacco use. They have increased heart disease, increased cancer prevalence, etc. And even when we try to control them, in other words, try to control the amount of smoke, or watch the amount that comes in certain races and certain ethnicities, and compare them to others that do the same thing, for some reason, Blacks do worse. They have a greater morbidity and mortality. In other words, they have more disease processes that occur, and they die quicker when they do smoke. And so, along with that smoking, along with all the ideas, we asked ourselves many years ago. I did this. This is a slide from many years ago, where we asked, does a health disparity exist? In other words, are patients from pancreatic cancer dying more at our centers that are Black? Are they white? Are they Latino? And here's just from my old institution at the University of Florida and my older institution at the Moffitt Cancer Center. And what you can see by this slide is that you see there's a lot more white people with this disease than Black at both institutions. So I thought, well, maybe, and again, this was an early study, many years ago. And I said, well, maybe Blacks are just not getting this disease. But when you looked at the national data, the data was absolutely the opposite. So Blacks were actually getting this disease a lot more than whites, but they weren't going to the major academic centers. And so why, right? Big question as to why. Is there a reason why they're not? And here's just that data to prove that. This data proves that Blacks get it more than whites, and they actually die more with this disease than whites do. So when we controlled for it, in other words, we took the same stage patients that were white, Black, and Latino, we're able to show that Blacks died from this disease more than whites. They presented at a later stage than whites. And therefore, there is a health disparity. And then the burden of pancreatic cancer was highest amongst Blacks. And we're not going to get too much in depth into this slide either, but for the most part, believe me when I say there are certain genes, not only in the tumors of Blacks, there's certain genes or signaling parts of this tumor, and we're talking like deep analysis of these tumors. They were different in Blacks, not only in the tumor, but also in the muscle. So again, as I said earlier, over and over again, we are all different. We have to appreciate our differences. And this might be why Blacks aren't responding to a lot of the therapies that are coming to these days. Maybe we should start considering other therapies. And while some of you might say, well, are we just really concentrated on curing this disease in blacks, whites, or Latinos? The answer is no. The answer is if we understand what one process does in one race and ethnicity and gender, then we'll start to understand what it does in others. This helps us all to not just throw everything, the same thing at everyone and not understand the differences. And here's just a quick look at some of the genes that, or proteins, the genes that are upregulated and downregulated in the muscles of blacks when compared to whites. And here's just some functions that were being upregulated in blacks when compared to whites. And so they were either upregulated or downregulated. The blue is upregulated, the red is downregulated. Again, very important processes for muscle function, but they were different amongst black patients versus white patients with pancreatic cancer. So again, supporting the differences that we have in race and ethnicity, and again, in supporting the importance of studies in this. This is Andrea Reiner, who's one of my residents from the University of Florida, and when she was able to show something very interesting, is that while we were proving that blacks had a worse outcome than whites, what we also proved was that Latinos or Latinx patients or Hispanics actually did the best, no matter where they went. So they weren't going to academic centers, some of them weren't anyways. They were going to community centers where there wasn't a high flow of these patients, and therefore some of the therapies were not as the standard as what we would expect. But it didn't matter where they went, they actually did better. And what Dr. Reiner did, which was very interesting, she broke it down even further to say that how is it that we can say that all Latinos or Latinx patients are the same? And what she was able to prove was that a Latinx patient from Miami is not going to be a Latinx patient from Los Angeles. The patient from Miami is going to have a different ancestry, right? And if we really think about it, it makes sense. Caribbean Latin patients have a different background, ancestry, different grandma, different great-grandma, different great-great-grandma than those from Los Angeles. There's so much diversity that we have to appreciate, even within our own, and even within the black race and ethnicities and that we need to appreciate as well. So it gets more complicated, but at least it starts to open up these ideas that we need to do this to better understand this disease. And this is what she showed, is that as we go through, that certain patients do better than others, regardless of where they went, and noted that Hispanic or Latinx patients did better. And I said earlier, we broke it down further, she was able to show that South American and Dominican patients actually did the best, impressively much better than what we would expect from the normal patient population here in this country. It's interesting, right? That South American and Dominicans actually do really, really well with pancreatic cancer when compared to everyone else here in this country. And so something, again, to be understood, better understood, to be able to help everyone. And as we started moving through, we asked the question why. Miles Cameron is an MD PhD student at the University of Florida who's done a lot of work with us, and he was showing that muscle mass as well as fat and fat content within the muscle makes a difference as well. I mean, this is all great biology. This is all great understanding, things we never knew about. And I think that if we start to understand it better, again, think of the things we could do to make these patients' lives better. And one of the things that people sometimes forget is when you think about a muscle, you think about your arm, your biceps, your legs, think about other extremities that are considered muscles, your abdomen, right? But people sometimes forget that the heart is a muscle, the diaphragm is a muscle. And as I said earlier, pancreatic cancer does not care. It produces a whole bunch of bad things throughout your body. And what it wants to do is degrade all the protein in your muscle to be able to survive. And one of the muscles that affects is your heart as well, which probably could also be contributing to your ability to really be strong during your therapy because of the cancer. Think about it. If your heart isn't functioning well, you're not going to move. You're not going to walk. You're not going to want to walk. And therefore, this disease, pancreatic cancer, will affect all aspects of your body, including your heart. And so something that we looked at, and we proved it by looking at different heart images from different patients and showing that patients with pancreatic cancer had worsening left ventricular mass. In other words, the hearts were smaller, and and we've yet to prove their function, but at least we knew that their heart muscles were getting smaller. Other areas of research that I think are incredibly important is looking at the oral microbiome. Now, that's a big word in and of itself, but Dr. Harriman's, who brought the idea forth, really looked at the effects of how the oral microbiome can affect not only oral health, but also pancreatic cancer. So think of it this way. It's what's in your mouth. And we know that people who have really bad periodontal disease, in other words, bad teeth, and they look like their teeth are falling out and they have bad dentition, they have really bad diseases, not only in their mouth, but throughout their body. They have heart disease, they have diabetes, they have high blood pressure, they have all these different things that are afflicting their life. And if you think about it, it makes sense that the first thing we introduce into our body is through our mouth. And so we started looking at the effects of how the oral microbiome or the bugs in our mouth might be affecting pancreatic cancer or other parts of our body. And so what Dr. Harriman decided to put together was the idea that the bugs in our mouth might be contributing to the growth of the cancer in our pancreas by either the bugs going down our throat into our stomach and then around our pancreas, or maybe by going through the systemic circulation, in other words, getting into our bloodstream and going to the cancer. Really great things, because we would ask ourselves, is there a way to, number one, be able to diagnose pancreatic cancer earlier by just looking at someone's saliva? And then maybe there might be something about antibiotics, which we have a ton of, that we might be able to use to try to control this disease, or maybe use it as a means to supplement some of the therapies we already have. Think of it that way. And what Dr. Harriman also showed was that we know that race and ethnicity is a factor in the oral microbiome. And that makes sense. My diet is not going to be anybody else's diet. I go home and I have Mexican food. And Mexican food is not going to be Southern food. And Southern food isn't going to be what they eat out west or in the Northeast. And so all of what we put in our mouth really does make a difference in the bugs that grow, that kind of live along with us in a kind of a home base, kind of in a symbiosis. We live together. And genetics also affects the bugs in our mouth. And smoking, remember that, right? I'm not ever going to drop that. Smoking can affect your dentition as well, and it'll change every bit of your mouth. So if I said earlier that smoking causes pancreatic cancer, and I said smoking can cause cachexia or muscle loss, and smoking can change your oral microbiome, you're starting to see the links between this. And as we age as well, our oral microbiome changes as well. So all these are important things to understand. So what do we do to address this disparity? Well, first of all, understand that we're different. Again, I keep on saying that over and over and over again, and we'll go back to tobacco a million more times until everybody on this Facebook Live either quit smoking, quit vaping, doesn't chew, or at least convince everybody around them not to do it, because it is one of the things that we can at least control. So we already showed that nicotine can cause cancer. It can cause it to grow. It can cause it to run rampant. It can produce a whole bunch of nasty things in the tumor that can lead to muscle loss, changes in your oral microbiome, all the things that we talked about. But we need to understand as well that we're all, like I said, over and over and over again, we're all a little bit different, and we should understand that. Some things we can control, others we cannot. Smoking, tobacco, vaping, chewing tobacco, all that we can control. And one of the things that I think we'll slowly end with is understanding what it is we're doing in this country. And so, well, we know that pancreatic cancer is a health disparity. One of the things that we're starting to look at is the inclusion of patients in pancreatic cancer clinical trials. Now, what does that mean? That means that there are a lot of patients out there with pancreatic cancer that we try to bring to these academic centers and even some of the smaller centers to look at ways to study the effects of some therapies that we know might work. And here's just a quick kind of diagram showing, at least the bar graph showing, that the majority of patients in clinical trial are white. Now that's interesting, because didn't I say earlier that blacks are afflicted with this disease more and they die more? And so when the percentage of individuals in these studies are in the 8-9% of blacks and Hispanics are in the clinical trial, how can we ever determine what drugs are going to work better in blacks than whites or Asians or Hispanics, etc.? I mean, how can we? And so if there's anybody out there that ever questions a clinical trial, this would be one thing that I would say has to change. that when asked to be included in a clinical trial in the year 2021, we must become more involved. We must have better representation in these trials, because we will never understand fully how these drugs could help all of us, including Blacks, Hispanic or Latinx patients, and whites, when all we're doing is testing these drugs on white patients. And while some of you might think, well, let them be tested and then we'll figure it out. But if I just prove to you that we're so different on a biological level, down to the cell, then we have to be a part of this. And so inclusion is incredibly important, and we'll work on that on our end. But patients have to be willing to be part of these trials, and we hope that I can convince you of that. And then collecting biospecimens. If you ever get asked to donate blood or donate tumor or donate specimens, God forbid, again, if you ever have cancer, do it. It's for a great cause. And while it might not affect you, it might not change your outcome, it could change millions of people if we figure out one or two things about your tumor that might be able to affect thousands, if not tens of thousands of people with cancer. So if ever get asked about giving blood or giving tumor or giving any aspect to help research in this, it is incredibly important, and I encourage everyone to do that. So as I said earlier, a Latinx patient from Miami is not going to be a Latinx patient from LA. And this is why. This is migration since the year 1500. Look at where everybody's coming from. And we're all coming from all different areas of the world. I mean, every bit of us has some difference. And so people talk about that 23andMe. How much are you European? How much are you African? How much are you this? How much are you that? That's incredibly powerful. And while, you know, that 23andMe is so much for kind of learning a little bit about yourself, in the future, it is that type of analysis, that type of ancestry analysis is going to be used to treat you for diseases, because we're going to know who you are and where you came from. And so it's as simple as understanding sickle cell anemia. There was a defense mechanism against people in the Middle East and in Africa. It was supposed to help people with not become afflicted with malaria, but that affects all of us, right? That it can affect all of us, especially those that carry the gene. And so again, ancestry is incredibly important for us to understand biology and then ultimately be able to understand cancer. And so why is that important? Because we're changing. Look at this graph. By the year 2065, half the population in this country will be a mix of white and other. So Hispanics are increasing in this country, Blacks will increase in this country, Asian will increase in this country, and we are going to equal the white population here. And so this country is going to be incredibly diverse. And so we need to understand our differences. Again, not because someone's better than other. It's because we understand our differences, we can better treat everyone. And so one of the last things that we're doing, and I think is incredibly important, and I encourage people to really think about this, is we're starting to look at Black patients and tumors from Africa, sub-Saharan Africa. And why is that important again? Because again, remember what I said, ancestry is important. Understanding where we came from, understanding the tumors from, let's say, Nigeria, compared those to patients in Florida or Virginia. I mean, if we can see the differences and see how the differences are changing because of our background, we can understand, again, the disease better and therefore be able to treat it better. So I have a lot of these on my wall, but I will tell you that the most important are these. So these are from patients of mine that I was able to operate on many years ago and to this day. And so I pride myself in being able to do this surgery and also be able to study it on a molecular level. But for the most part, I wake up every day and go to sleep every night thinking that I can not only help one person at a time, but I can help thousands in the future with the research that we're doing. So I encourage everyone to really think about that. And so diversity is important. There is a health disparity. We need to address it on all levels. And obviously stay away from things that can cause cancer, that can promote cancer, and ultimately stay healthy and strong. So I'd like to thank everyone for allowing me to give this talk today, and I appreciate your attendance.
Well, thank you so much for that informative presentation, Dr. Trevino. We'll now open this up to a few questions for the final portion. And before I address any that may have come through the comments on Facebook, I'll read a few that came in advance. So first, you touched on this a little bit, but do you mind kind of going over, is pancreatic cancer hereditary, and can I get tested to find out if I'm at risk?
Right. So there, about 10% of people with pancreatic cancer have a hereditary component. In other words, there are certain genes that run amok. And when those genes run amok and you kind of maneuver through your life and have children, sometimes you pass those genes through generations. And so the answer is yes, it can be. It's not a really large percentage, but if, like I said earlier, if you have a family member that had it, and then your grandma had it, and great grandma had it, or great grandpa had it, and it keeps on passing through, it should always be checked. And so people who have a just continuation of cancer in their family should always seek a genetic counselor to be able to review their hereditary components of this, or any cancer in general.
Okay. We definitely heard you talk about nicotine and tobacco, but are there any other preventative measures you can take to lessen the chances of developing pancreatic?
Yeah, there are toxins out there, like I said, chemicals, drinking too much, giving yourself pancreatitis, which can happen with too much alcohol use, poor health, poor dentition, as I said, when you look at the oral microbiome. So there are a lot of things that you can do, just maintaining a healthy physical lifestyle is what's most important. Staying away from things that can cause cancer has been over and over and over beat down in this conversation. But I think those are incredibly important topics that people need to understand. But at the end of the day, I've had people walk into my clinic and pretty much tell me that they never smoked, they never drank, they never did anything that was bad, and they're completely healthy, and they developed this. And that's what's called sporadic. And that just means it occurs. And it's kind of saying that it's just a kind of a bad luck thing that happens, but it does occur, and some things we just can't control.
Okay. You also mentioned this a little bit, but how can I donate tumor or blood samples or tissues?
Yeah, I mean, you would have to come see me in my clinic, but yeah, if you, it's incredibly important for that. And not only do we take patients with cancer, we also take normal patients that want to donate. It just provides a really good control for the things that we do, because we always want to know what a normal person will look like to compare that to what a person with cancer looks like, because that's how we know the differences are there, that it's not just based on age or other factors. And so there are tons of researchers out there at academic centers that do this work, and there's tons of people that would accept volunteers at any time. I can't say it's as often as donating blood, mm-hmm. But yeah, it's important. But I think linking yourself up with a researcher at an academic center like myself is the way to do it.
Okay. You talked about clinical trials as well, but are there any clinical trials maybe available at Massey or elsewhere that you know of for pancreatic?
Yeah, so every major academic center has one form of a clinical trial or another. Even some of the smaller cancer centers around Richmond have them, and so they're there. It's just a matter of finding them. And so there are websites for this. You can look up clinical trials, clinicaltrials.gov, and you can literally put in a search for whatever trial you're interested in, whether it be pancreatic cancer, colorectal cancer, lung cancer, and you will get the gamut of clinical trials throughout the entire country, where patients or family members or even investigators or researchers can look into. And so there are a ton of things out there for clinical trials, and it's just a matter of it's a Google search away.
Okay. Can pancreatic cancer treatment affect a patient's fertility or ability to get pregnant?
So the answer is no. It cannot specifically affect a person's fertility or ability to get pregnant. But what it does, you have to remember that, again, this disease is incredibly deadly. And so 6 months to a year, if you get caught in an advanced stage, is typically the life expectancy, which is a horrible thing to say. But that, for the most part, is what the data would suggest. The other thing about the fertility and ability to get pregnant for females, this disease does not affect females within the childbearing ages, which is a good thing. I mean, have I seen it in young patients? Yeah, I have, but it is incredibly rare. For males, it does not affect your fertility. But again, with this disease, I think unfortunately, the last thing you're thinking about is trying to reproduce. But yeah, it doesn't affect males, and females will not be affected within their childbearing age most of the time.
Are there survivorship support services available?
Oh, yes, absolutely. And I think that that's one of the key things. And I will tell you that there are 3 things in my mind that will allow you to have a long life with this disease. One is having good mental health. In other words, really understanding that we have to work really, really hard mentally, being positive, saying that you're going to beat this disease really does help. The second is nutrition. Nutrition is incredibly important. We talked about that. Maintaining good nutrition throughout your care is incredibly important. And the third thing is what I would say is probably one of the more important things is spiritual. And so all these survivorship support programs will allow that. It'll allow people to really talk with you. You feel like there's a support system that affects your mental health, that affects your psychological health. It'll affect your faith in some cases. And as what I tell my patients, I don't care if you believe in Buddha, Allah, Krishna, or Jesus Christ. You have to believe in something and hold on to something. And so, yeah, I think these support systems are incredibly important. And for me, as my patients come through their operations, I refer them to these survivorship programs that even at Massey, we have an incredible one to really help patients maneuver through and understand that they're not alone.
Great. Here's definitely a big one. Can you be screened for pancreatic cancer?
You can. But unfortunately, in this country, in this day and age, it's going to be hard. I mean, lung cancer screening, we just came through, which was a fight for many, many, many years. Colorectal screening, we've had for quite some time, and breast cancer screening, we've had for some time as well. But it's a fight to believe this, that we can get this, because the insurance companies don't really want to just start screening people with CT scans all day long, and it's not costly. What they would say, it's not cost effective. And so insurance companies lose money, and they don't want to lose money, so they don't want to pay for things that might not show anything. But I think it's up to us. It's up to us as patients, as family members, to empower ourselves to understand this disease a little bit better. So why I say that, as I said earlier in my talk, if suddenly you're an otherwise healthy individual at the age of 50, 60, 70, and maybe even 80, and all of a sudden develop diabetes for no reason when you've maintained an incredibly healthy lifestyle and you have not abused your body, you have to ask yourself why. And for me, if I was that patient, I'd be knocking on my primary care physician's door and say, hey, listen, something's not right. And you have to investigate it further. And that's when you start to push things. You start to push the envelope and say, okay, I would like to get a scan. I would like to get something to look at my pancreas, because I shouldn't have just become diabetic. Don't tell me it's age that does this. Now, am I saying age doesn't do that? No. But I'm telling you that in some cases, if you can catch this early enough, if 1 out of 10 people got caught early enough because they went to their doctor and said, I subsequently developed diabetes and all of a sudden I'm losing a lot of weight and I don't feel good, if we can catch that 1 out of 10, I think that's worth it. And so while there is no screening program for it now, unless you have a genetic component where, like I said earlier, mom had it, grandpa had it, great-grandpa had it, etc., unless you have a genetic component, you have to be able to be aware of what the pancreas does, where it's at, and the pains that can occur with it or the symptoms that can occur with it, as I mentioned earlier.
Well, thank you. This has all been really great information. I think that's it as far as questions. Do you have anything else you kind of wanted to add before?
No, I'd like to thank everybody for attending, and I look forward for future talks like this, and this has been great. Thank you again very much.
Well, we thank you. It was such a pleasure having you join us for this important discussion. And for more information about pancreatic cancer, you can follow at VCU Massey Cancer Center on Facebook or visit Massey at masseycancercenter.org. Once again, thanks, Dr. Trevino, and anyone who joined us this evening. Have a great night.
Great. Thank you.